Hello, I'm John Marini from the University of Minnesota in Minneapolis and St. Paul in the United States. I'm going to be speaking to you today about the conflict that's been going on among physicians and scientists regarding COVID-19 management of respiratory failure. And I believe that we can put it all together if we consider the changing physiology of this unique disease. There is a paper recently published by Daniel Brody, Phil Dellinger, and myself in intensive care medicine, which explains our philosophy linking the early and the late stages of COVID-19. And I'll come back to that as I conclude my presentation. The shared observations about COVID-19 and those features that are uncontested are an abrupt deterioration occurs after days of smoldering infection. Respiratory system compliance is not invariably low in the presence of severe hypoxemia. The incidence of blood clotting appears to be high in hospitalized COVID-19 patients, and this affects the lung as well as other organs. Early CT infiltrates occurring in severely hypoxemic patients are often scant, peripheral, and characterized by atypical ground glass or crazy paving, as the radiologists call it, despite severe hypoxemia. Prone positioning and PEEP do improve PaO2 and FiO2 ratio, but not necessarily ventilation efficiency. And respiratory failure often resolves slowly in the most severely ill who do not survive. Puzzling features include many, but these three are important. Do patients progress to diffuse airspace disease via patient self-inflicted lung injury, so-called PSILI? Does the fact that CARDS patients meet the Berlin definition mean that these patients will respond to standard approaches and guidelines for ARDS? And does disrupted vasoregulation with minor shunt explain the severity of early hypoxemia? The COVID ARDS characteristics that have been pretty well documented is profound hypoxemia and infiltrates that qualify as Berlin-defined ARDS, which is an oxygenation-based criterion. And CARDS does not follow the conventional ARDS paradigm. Early unusual features are lungs that are relatively gas-filled despite severe hypoxemia. There's a relative ease of ventilation in many patients early on, an unusually slow resolution of respiratory problems later on. High ventilation requirements are seen almost from the beginning, but often without respiratory distress, sometimes called happy hypoxemia or silent hypoxemia. And this may be due to disordered respiratory drive that favors larger tidal volumes and relatively diminished frequencies. The epithelial airspace flooding component is much, much less than the endothelial vascular component early on. And this leads to hypoxemia due to VQ mismatch, which is greater than the shunt-related component, at least early in the disease. Here's an example of early ground glass infiltrates in crazy paving. Note the peripheral locations. The relatively gas-filled lungs, recruitable zones are present, sparse atelectasis, and relatively little consolidation despite severe hypoxemia. Not only that, but if you look at patients at various stages of ARDS and CARDS, the distribution of tissue infiltration is similar in the two. It's dependently distributed in both ARDS and CARDS. The gas volume in CARDS is quite differently distributed. It's evenly distributed, not just in the non-dependent regions. And this is definitely a difference with conventional ARDS. CARDS has more gas volume and better compliance than typical ARDS. This is a paper that's under evaluation by Davide Chiumello and colleagues, of which I was one author. The reason for all of these peculiar features is that the coronavirus attacks from the vascular side. This is well agreed upon now, but wasn't so much so even 4 or 5 months ago. This is a nice paper by Ackerman and colleagues that shows that pulmonary vascular endothelitis, thrombosis, and angiogenesis occur simultaneously to differing degrees as time proceeds in COVID-19. There is some very graphic depictions of the microthrombi that are seen in the alveoli of the lung, as well as lymphocytic infiltration in patients who die with COVID-19. A very recent paper by Pelosi's colleagues in Genoa uh, d- show a remarkable fibrotic change in the lung in patients who die with COVID-19. This is in the Lancet, published very recently. And it really fits with the angiogenesis piece because angiogenesis may eventually promote fibrosis. So, respiratory consequences of COVID vasocentricity include problems for drive, gas exchange, and mechanics. The angiotensin mediated sensitivity of the carotid bodies, the brainstem level alterations of the breathing controller uh, influence the patterns of mechanical ventilation, not mechanical ventilation, total ventilation that you see, and their distribution of tidal volume and frequency. There's a disrupted ventilation perfusion matching, which is particularly prominent early on, much dead space generation, fibrosis promotion, microemphysema and gaseous distension, and relatively less volume contraction than ARDS. Uh, there is an adverse PEEP sensitivity created by this vascular component that exceeds the airway component. If we follow the conventional PEEP tables of the ARDSNet, we will see PEEP values that are really quite high. They're in a range that is probably not appropriate for the degree of hypoxemia that you see in COVID-19. 14, 16, even greater than 12 are probably not advisable, at least not in the early stage. The familiar effects of PEEP are well known. If you have successful PEEP recruitment, you have a reopened vascular bed, better oxygenation, and CO2 exchange may be stable or improved. Whereas if you have a non-recruitable lung in conventional ARDS, you have an increased pulmonary vascular resistance, increased stress throughout the lung without real benefit from positive end expiratory pressure, and you may see a CO2 exchange problem. Now, here's early cards. What you see is that there is a small amount of tissue that has a reopened vascular bed and better oxygenation, but the other piece is overdistended. The gas-filled lungs are overdistended in many places. This redirects blood flow to regions it should not go, and it increases the dead space. This mismatching of ventilation and perfusion was nicely shown in this paper by Mauri, Pezzenti, and colleagues from Monza in in Milan now, in critical care medicine. Now, one of the important questions is when to intubate these patients. Note that vigorous breathing efforts increase transpulmonary pressure and violate the objectives of lung protection and may lead to PCILI, independently of whether or not the patient is spontaneously breathing or assisted in their breathing. You don't want them to vigorously breathe. It puts traction on the lung. And when you put a lot of power through the lung, through the process of vigorous breathing, you will have a shrinking baby lung that concentrates that power and causes trouble. In fact, the baby lung does not stay stable in response to an injurious pattern of mechanical ventilation, but actually shrinks over time with intolerable fibral strain in the matrix, progressive stress loading of those units that remain, unit dropout, increased ventilation load on those that remain, increased specific power, and we call this the Villi vortex. This I did with Luciano Gattinoni, published recently. The higher transpulmonary pressures during spontaneous breathing increase both airspace and microvascular stresses, which encourage edema formation. So in COVID-19, you initially have a disrupted control of ventilation to perfusion, which leads to hypoxemia. If you use non-invasive support, most of those patients will do relatively well. If you allow those patients to progress to the point of vigorous inspiratory effort, villi develops, vessel stretching and increased edema develop, power concentrates, baby lung shrinks, and this villi vortex becomes even more intense, possibly accounting for why they tend to precipitously decline. Now, a lot of heat has been taken by Dr. Gatnoni, who spoke at this symposium as well, suggesting that people might be of two different types in COVID 19, a type L and a type H. The L type is earlier, milder. H type is later and more severe. Later, it tends to look like ARDS. Earlier, it looks very much like I described earlier. And the oxygenation may be quite similar in the two situations. This paper, again, that we just published in Intensive Care Medicine, takes you through with the pathophysiology from one point to another. This COVID elephant that the blind men are trying to put together has better compliance, ineffective recruitment, atypical PEEP responses, VQ mismatching, gas-filled lungs, ground glass infiltrates, adequate organ function, limited inflammation, and even some suggestion of immune suppression, which over time change to worse lung compliance and more familiar responses. Now, this from a paper in JAMA that I published with Luciano, talk about the time course and the treatment approach to ventilation support for these patients. Before intubation, you want to assure adequate gas exchange and avoid PCILI. And later, after the patient's intubated, you want to minimize the PEEP that you need to use. You may fuel free early on if the plateau pressures and driving pressures are within accepted boundaries, to allow a slightly larger tidal volume so that it does not compete too much with the controller that the patient has due to CARDS. You want to minimize transpulmonary and vascular stresses. After intubation, it's been the rules are pretty much the same as usual. When you are in the type H or later phase, PEEP can go as high as 15 centimeters of water during that period of time if necessary and the patient's recruitable. But early on, you want to keep PEEP lower than is customarily used. You might use a more liberal tidal volume. And there are rationales for those steps that are outlined in the article. And in the weaning phase, to avoid a reversion to previously worsened pulmonary state by causing villi and worsened edema, you want to make transitions cautiously, avoid abrupt changes, etc. So the takeaway points are these: prevent vigorous breathing and high transpulmonary pressures, avoid high PEEP, monitor mechanics and ventilation efficiency, prepare for a marathon, not a sprint. And that is the end. Thank you.